Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians where Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have learned while we were memorizing the Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. This podcast is intended for medical professionals. The information is to be used in the context of your own clinical judgment, and those on this podcast accept no liability for the outcomes of medical decisions based on this information. As the radiologists like to say, clinical correlation is required. This is not medical advice, and even though the magic of podcasting may make it seem like we're speaking directly in your ears, this does not constitute a physician-patient relationship. If you have a medical problem, seek medical attention.
On today's episode, we speak to orthopedic spine surgeon Dr. Seth Grossman about neck and back injuries, when to worry, when not to worry, and why we should all be doing yoga, Pilates, and once a day, get on our bellies and try to fly like Superman. Welcome back to the Physician's Guide to Doctoring. On today's episode, we have Dr. Seth Grossman, a spine surgeon in New York and New Jersey. Seth, thanks a lot for speaking with us today and helping to, as you put it, demystify the spine.
Sure. Thank you so much for having me.
Could you just give us a little background on your training?
Sure. So I went to medical school down in Philadelphia at Jefferson Medical College, which is now Sidney Kimmel Medical College. After that, actually before that, I did some graduate work in computer engineering. Then made a little change in career. So I went to medical school down at Jefferson, and then I did my training at Albert Einstein Medical College, Montefiore Medical Center in the Bronx. And then I did fellowship training in spine surgery at University of California in San Diego. And since then, I'm in private practice now. I'm in a group. We have offices in Bergen County in North Jersey, and then also in the city, a few locations in the city.
New York City.
New York City, yeah.
This podcast is international, so
okay.
Our audience is broad. So Seth, you were going to talk to us about demystifying the spine, and so what are some of the things that you think all doctors, whether they treat related conditions, whether they're referring physicians like primary care physicians or ER doctors, or treat things that are completely unrelated? What should all doctors know about the spine? And I'll give you an example. Let's say because in New York and New Jersey here, we can get a lot of snow. Your neighbor is shoveling his driveway or her driveway and throws out his back. Whatever that means to me, an otolaryngologist, probably means something very different to you. And he says, hey doc, because everybody calls us doc if they can't remember our name. Hey doc, I just hurt my back. What do I do? So what do I ask him to make sure that it's not a medical emergency? And should it not be, what do I tell him?
Right. So it's a good question. So back pain in general is extremely common. It's one of the most common reasons for loss of work in the United States. It's one of the most common disabilities. People have to miss work. And pretty much everybody at one point or another is going to throw out their neck or their back. So something I see a lot in my office, something that, I hear, people, my neighbors and such. So it's a very common occurrence. And most of the time, vast majority of the time, patients are going to be fine. Most of the time it's reassurance. Throw out your back, you got to rest it, ice, basically just kind of taking it easy for a few days, maybe taking some NSAIDs, and that's, 90% of the time patients will get better and within a period of time. So red flags that you want to always, look for is any kind of weakness or numbness. So just in general, the spine, as an orthopedist, really any specialty is a joint, is a series of joints in your back, just like, your neck and your back, just like a knee or a shoulder. So you can pull it, you can strain it. There are muscles and ligaments and tendons that can get injured and they heal much like any other joint, they rest, ice, wrapping it, that kind of thing, babying it. The added complexity in terms of the spine is that there are major nerves that run through that joint. So if something were to dislodge or press on a nerve, that can be dangerous in that you can damage that nerve, and nerves depending on how badly that they're damaged or how much pressure is on the nerve, may not necessarily heal. So you can end up, God forbid, with neurologic dysfunction, which can be permanent. So that's where I think everyone, people get a little bit concerned, a little bit overcautious with the spine. So anyone who's complaining of a neurologic type of a symptom, that in my mind, and in any doctor's mind, should be a red flag. So, doc, I pulled out my back, it's killing me, it's throbbing, my pain is 10 out of 10, I can barely walk. That's not an uncommon complaint, and that I see every day in my office. And again, I would say up to 90% of those patients are fine within a week. But doc, I pulled out my back shoveling snow, and now my foot is dragging, and I can't feel my toes. Is another added layer to that, and that may be something that is a little bit more serious.
Okay, so numbness, tingling, weakness, does that warrant an immediate ER visit, or should they follow up with you in the office?
Yeah, it's a good question. Certainly, someone that should be seen soon. Whether or not it's an emergency, I guess, would depend on how bad the neurologic dysfunction is.
So a little numbness, a little tingling, but loss of function probably is. Would you say that that's like a hard red line?
Yeah, I mean, you can't lift your toes. That's really an emergency. You have a little bit of tingling in your toes. That may not necessarily be something that has to be evaluated in the emergency room, especially during a snowstorm.
So sounds like the difference is sensory versus motor function. If it's motor function, it's an emergency. If it's sensory, then you can wait for an office visit.
Yeah, I would say generally. Obviously, that's a generalization, but
clearly depending on the degree. If it's a little bit of numbness,
right.
A little bit of tingling, if you can't feel any of your toes or something, but clearly,
right.
Again, as the radiologists like to say, clinical correlation is required.
Clinical correlation, exactly. And then again, I'm sure everyone has heard the term called Aquinas syndrome, which is very rare, but obviously saddle anesthesia, bowel and bladder incontinence, anything like that happens soon after an injury is also, that's an immediate, trip to the emergency room. I will sort of preface that in that, patient hurts his back, also has a little bit of prostate issues and has urinary retention that's been ongoing for, 10 years, and he takes medication for it. It's not necessarily called Aquinas syndrome. And I think that we're very quick to jump to that. So loss of bowel and bladder, basically where you can't feel or control your bowel and bladder movements, that's an emergency. Having chronic issues, constipation, urinary retention is not a called Aquinas.
If these things far preceded the injury, then they're probably unrelated to the injury.
They're probably unrelated, and it's probably not an emergency.
And even if it was related, it's not. The fact that it's long history speaks to the lack of urgency. Okay, so let's actually get away from the urgent ones, because those are the ones that are going to be managed by you. What about the ones that aren't urgent? So you said, well, a few days of rest, baby it for a little, some NSAIDs. Are you more specific than that with your patients? Do you tell them more specific instructions, 3 days, 5 days, a week, wait until it feels better? Or is the data not just out there? And so, I sometimes have trouble with this in my practice. Like, people are sometimes looking for a specific answer, like a week, right? If I don't feel better from my sinus infection in a week, does it mean that the antibiotics aren't working, or in 3 days? Like, they're looking for something hard and fast. And the fact of the matter is, if you're going to be giving someone a hard and fast number, you're going to be kind of making it up. Or are there recommendations?
Right. That's a very good question. So, there are recommendations in terms of, the radiologic societies and orthopedic societies have released guidelines in terms of when you should, say, order an MRI, get X-rays, do advanced testing. And to be honest with you, in today's day and age, especially where we are in the New York, New Jersey area, I feel like patients, pretty much demanding an MRI, minute one when they walk into your office. So, In terms of managing it, again, even if it is, I tell patients that, you pulled your back out, it's probably a muscle sprain, but even if it is a herniated disc, which can be more serious, even that is going to get better with time and not necessarily need any kind of intervention. So I generally try to, I give patients either a course of NSAIDs or even steroids for a week. And I have them tell them to come back and rest. If they're working, I give them a work note, especially if they do some manual labor. And I say within a week, if they're not much better, then we can go ahead and start ordering up tests and doing interventions and that kind of thing. So roughly, I basically say a week. I don't know that that's an evidence-based recommendation, but you got to give it a few days. Everybody's a little different, but typically, most of these spasms and sprains will at least be 50% better, if not more, in a week.
And so does it improve outcomes to rest if it's hurting, or should they actually start to push will they recover faster if they actually push their limits? Like what I'm asking is, where is that inflection point? Not necessarily time-wise, but time or symptomatically, or
Right.
they shouldn't lay on the couch until it feels 100% better, right? So
Right.
at least where do you believe that inflection?
At what point? Right. Sure. So, I think if we extrapolate this out to a year, right, I think all patients are going to pretty much be better at that point, whether they rested it for 2 weeks or 4 weeks. Or I personally, I definitely push, physical stretches, walking, physical therapy. Definitely, I think certainly in the short term, definitely has a great effect. It can really help. But in the really immediate, doc, I just threw my back out shoveling snow. There is a time where I tell patients really just rest. You don't need to be lying in bed 24 hours a day to the point where you're going to get a blood clot or something like that. But, really just stay off your feet, try to rest, ice it, minimize your any kind of bending, lifting, and twisting for at least a few days. And again, after that, then you can, you start to go do some stretches or see a therapist, have a massage, something along those lines to try to get the muscle, get the blood flowing to the muscles a little bit, try to move a little bit before, stiffness and sets in.
And is it any different for a neck injury, or you're saying this is not just lower back, this is the entire spine?
Yeah, I would say, my advice is pretty much the same for the entire spine. The neck can be a little more acute. The spinal cord, to get technical, runs down your cervical and thoracic spine, and it ends around the top of your lumbar spine. So most of the time you have a disc herniation, even a pinched nerve, a radiculopathy, it's a nerve root, which is a little bit more tolerant of pressure and perturbation than the spinal cord itself. So if you have an injury where you have pressure on the spinal cord, that also can that can be a little bit more acute. But in general, just shoveling snow or sleeping wrong or minor trauma, you're unlikely to have a major event where you're having acute compression of your spinal cord.
Now, have you, just a little aside, there's this text neck phenomenon. Have you seen this at all?
Sure. I think that's just, this text neck is just in the greater scope of 21st century living. So we spend our days on the computer, we're on our phones in between, we're basically always looking down. And also as we age, our disc degenerates. So your whole, basically you're kyphosing, or your whole body is being pulled forward. It's definitely a problem. And it's, I talk to my patients about doing strengthening, specifically their posterior chain, so their extensor muscles, working on flexibility, but specifically with extension type activities, because we tend to lose that naturally with age, but even more so now in today's society where, our whole life is spent kind of crouched over something.
Can you give some examples of that? That sounds like something that is really great advice for human beings in general. And again, kind of the idea behind this podcast, right? What are the things that every doctor should know? That sounds like something every doctor should know. So what are some good exercises that that we should maybe
that can help? Yeah. So anything where one thing that I tell a lot of patients is to do like a Superman, where basically if you get a mat, you put it on the ground, you lie on your stomach, and you put your arms out like you're flying, like you're Superman, and then you basically want to work on extending and lifting, reaching your arms and your legs out and up as high as you can, and holding that for 5 seconds, 10 seconds, or doing sets of that where you're basically working on strengthening your extensors. That's a really good one to do at home. If you have access to a gym, I mean, they have these machines, these boot ham developer machines where you can go and you can also work on extension of your back, of your neck, that kind of thing. So the Superman's a good one. You can also do it, if you have an exercise ball, you can work on if you lean over the exercise ball with the exercise ball in your stomach and you're working on extending your arms and your legs, that kind of thing, I think can be beneficial.
So as a spine specialist, when you are meeting with your patients and working on your electronic medical record, are you sitting on one of those balls?
I wish. No, it's not. Unfortunately, the Googleization has not happened in medicine. There are no foosball tables or beer dispensers in the office, unfortunately. But I do tell patients. So another thing to expand upon, on top of just the Superman activities, is yoga and Pilates. I tell everybody, I do it myself. I try, and I tell all my patients to. You don't need to go to expensive. You don't need to spend a lot of money. You can go on YouTube and just type in yoga exercises for your back. Just the basic yoga poses like downward dog, cobra, cat cow. I don't know how many yogis are out there, but those are great exercises for your back, and they all work on flexibility, spine flexibility, and extension. So I think it's very beneficial.
I think the classes also, in terms of habit formation, right? I think going to those classes gives you a sense of accountability because you meet the other people there, and oh, wait, where were you last week? So it gets you to keep going, and then there's a sense of community as well, which.
Oh, definitely. If you can incorporate that as part of your life and go a couple of days a week, I think that you see a dramatic improvement, especially in patients with chronic pain, chronic issues, kyphosis of their back and neck. It certainly can be huge. But even if they can't, some patients don't have the time or the means, even putting on a video for half an hour once or twice a week. But definitely, if you can join a group and go to a class on a regular basis, I think patients would see dramatic improvements. So it's rare to see, to be honest with you. Most of my patients, I tell them, but it's hard in today's life to make time.
Yeah, I hope to incorporate that into the podcast at some point and get some of these experts on habit development in here, so that when we do give advice to our patients, it can be in a way that is realistic, where we can expect them. It is a realistic expectation that they will take the advice, because we want them to do all of these things, but how can we get them to do it is the challenge, right? We all want them to eat better and exercise more and sleep more and have less stress. And
right.
But how do we actually get them to do it? There's this pervading idea that we are not holistic, right?
Right. We have a sick care system more than a healthcare system.
Exactly. Oh, exactly. Well put. And so it sounds to me, if you're recommending these things for your patients, that you are a holistic doctor to me, because you are considering the whole patient and not just the one injury that you happen to be seeing them for. So.
Yeah, no, definitely. And it's hard as a physician as well when you're, pushed to see more patients and you have X amount of time with these patients, and, it's enough just to get the spine exam down. But I do try, I see a lot of patients, with metabolic syndrome that are obese, and that's a lot of extra weight. If you're every pound of weight over your ideal body weight in the daily biomechanics of going through your life can be up to 4 pounds extra on your spine. So I tell patients, if you're 10 pounds overweight, it's like carrying a 40-pound backpack around. Imagine doing that all day, your back would hurt. And these patients, you can do the math. Some patients are, pretty heavy. So I ask them, maybe you can, try to cut out sugary drinks or try not eating after a certain time. Small things, it's hard to go on a radical crash diet and they have a high failure rate, but just being a little aware of how they can at least make some changes.
And actually, in an upcoming episode, I'm going to be interviewing someone who specializes in obesity research, who will be talking to us about how we should be addressing that specific population. There was just a Huffington Post article going around my physician friends on Facebook about how bad doctors are about talking about obesity. And I think with regards to that article, there's probably just a few standout callous individuals. I think most of us are saying things like you're saying, right? Like trying to give them some advice that is reasonable and not discouraging, right? Like, maybe not eating after 9 o'clock at night. That's a reasonable recommendation that is easier for them to stick to, as opposed to like, don't eat carbs ever again, right? Like that's not
you need to lose 50 pounds. I mean, it's a lot easier said than done.
Exactly.
And honestly, again, if you say it in the wrong way, you can certainly get some poor online reviews.
Exactly.
For as a result. But
there's that.
I think if you say it in earnest and you're somewhat sensitive about it, patients understand, and they know. Patients know when they're, they put it together that being obese, being out of shape is one of the root causes of their back pain, because it just makes sense.
So let's get back. So that's for a later episode. I'm really looking forward to that. But I'm also really enjoying this interview. So Seth, let's talk some more about some of the common consults that you see. What would you say is the most common thing that you see? One of the most common that you think would be useful to discuss?
Well, I mean, again, I see obviously all day long, I'm seeing neck and back pain. Again, just especially in this area, the usual, it's, the patient has neck or back pain and maybe they get some NSAIDs or maybe, and then they get an MRI and the MRI sounds terrible and they, and then they show up in my office.
How often is there degenerative disc disease on an MRI? Like, just if you, I don't know, just give me some statistic that you know of.
Yeah, extremely common. I use the patient's age as the percentage. So if you're 50 years old, if I took 100 healthy 50-year-olds with no back pain at all and did MRIs with them, probably 50% of them would have significant degenerative disc disease. If you're 80, that number is 80%. So that's sort of a rough. I think there are some studies to show, but as a rough generalization, it's your age is the percentage of patients your age that would have findings on an MRI.
So those findings could be used to explain pain that's there, but it's not predictive of pain.
Yeah, it's a very good point. It's a very good question, and honestly, makes the job tough sometimes because it's very common to see herniated discs. It's very common to see degenerative discs, bulging discs, and it's not so easy. In some cases, patients are in severe, pain to the point where they need surgery for it, and in some cases, it's an incidental finding where it was there already, and it's just a muscle spasm. So it can be a challenge and some people for some reason feel it. Pain receptors are different or whatever, but some patients are more sensitive to those changes, and some people are not.
I think this was a very productive conversation. I really appreciate you taking the time. Is there anything else that you wanted to discuss today that you think we might have missed?
Yeah, I mean, just in general. So just to expound a little bit more on that visit. So in general, if you're a 53-year-old man and you pulled your back out, shoveling snow, and you ended up with an MRI, more likely than not, to a layperson, even to another doctor, it's going to sound terrible. That's, radiologists, like to be thorough and they like to describe everything, and it's going to see things like spondylosis, disc herniation, impingement. But really, to tease out all that, really the thing, when I obviously I read all my films, I look at all the reports, I examine the patient, I try to make the most educated, decision as possible. But at a glance, when I look quickly at an MRI, what I'm looking for is things like stenosis, and more central stenosis, like if there's pressure on the canal, in the middle of the canal where the spine runs down, if that's being compressed, that can really be an issue. If there's any kind of, obviously a fracture or a tumor, that's a red flag for everyone. But stenosis or significant, malalignment of the spine, the spondylolisthesis, where bones are slipping on each other, I look for conditions where the nerve is compressed, because all that other stuff is very common and usually not really a problem. Certainly not in the short acute term.
Well, great. I really appreciate you taking the time to talk to me and talk to the audience. I think clearly Pilates and yoga now will have to find their way into my regimen somehow. It's not just going to be clean and jerk, and which is
especially if you're going to do clean and jerk, you got to do some yoga and Pilates in there as you get older.
Well, I can't touch my toes. That's a problem. I'm almost. It's going to start catching up with me. And clearly the Supermans need to find their way into my routine, because myself and, I'm sure almost all doctors with the EMR, or even, without the EMR, I dictate a lot of my notes, still hunched over my phone, hunched over my computer.
Yeah.
And you know what? We're surgeons, hunched over our patients in the office and in the operating room.
Yeah, your whole life is spent in flexion of your spine. So you definitely want to focus on extension and try to keep that strength and mobility. Very important.
So all of us need to start doing the Superman before we go to bed. Maybe that's.
I want to see worldwide. I want to see people doing Supermans. That would be my wish tonight.
All physicians and everybody, Superman, 5-10 minutes every night before bed.
Yeah, I'd be out of a job, or I'd be a lot less busy probably. So maybe I don't want people to do that. I have to think about it.
There's a little conflict there. Okay. Well, thanks a lot, Seth. Again, I appreciate you taking the time. It's been a pleasure.
Thank you so much. Thanks for having me.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. Find all previous episodes on iTunes, Stitcher, Google Podcasts, or wherever you get your podcasts, and write us a review. You can also visit us on Facebook at facebook.com/Physician's Guide to Doctoring. If you are interested in being a guest or have a question for a prior guest, send a message or post a comment.